طبعا بستغل الفرصه ان انا اشكر سير اليكس على اختيار المواضيع. الواحد من ساعه ما قعد كده في سيمباثيك تون زايده وتكارديا فكرتونا بامتحانات الدكتوراه، عناوين كلها ام دي يعني. بروفيسور احمد عبد الحميد هيكلمنا على Thyroid Dysfunction and Cardiovascular Health. اتفضل دكتور احمد.
السلام عليكم. حاجه اشرف الدكتور ايهاب على هذه الدعوه الكريمه. دايما انا مظلوم ببقى في الاخر بعد دكتور تامر معاها دكتور علياء بعد المواضيع الشيقه اللي هم بيقولوها. نحاول بس احنا دلوقتي back to the basics. الموضوع هيبقى ان شاء الله اسهل. نتكلم النهارده على cardiovascular effects of thyroid disorders. This is my agenda. Actually, the role of thyroid hormone in aggravating cardiovascular disease is well recognized. Thyroid hormone receptors are present on the heart and the blood vessels. This relation is not new. You can, in 1878, Sir William Greenfield, doctor from London, described in autopsy of 30-year-old female patient these words: the patient with mixed team. Much serious effusion in the pericardium. The heart was large, the arteries were everywhere thickened, and the larger ones are atheromatous. Back to the physiology. What are the thyroid hormone actions on the cardiovascular system? As we all know that the thyroid gland secretes 80% T4 and 20% T2. T3 is considered the biologically active hormone. Much of the T3 in the peripheral circulation is produced from T4 by peripheral deiodination. Thyroid hormone receptors are much more sensitive, around 10 times more sensitive for T3 than T4. Deiodinase 1 is active in the liver and the kidneys and produces 15 to 20% of T3. Deiodinase 2, which is expressed in the heart, in the brown adipose tissue, pituitary gland, and in the brain, produce 80 to 85% of the circulating T3. And deiodinase 3 catabolizes both T3 and T4 into inactive forms, thus terminating the thyroid hormone action. Thyroid hormone action on the heart is produced from a genomic, non-genomic, and cardiovascular and effect on the cardiovascular hemodynamics. The genomic effects are by binding to nuclear receptors, leading to expression of genes, and this is a slow process. And there's non-genomic action on the ion channels on the cell membrane, and it is a rapid action. Effect on the cardiovascular hemodynamics produced from the effect on the peripheral circulation. In the cardiomyocytes, the thyroid hormone are transported by MCT8 and 10 into inside the cells, where T4 is converted into T3. The T4 does not have any gene expression or gene transcription properties. The T3 binds to the nuclear receptors for the thyroid hormones. The thyroid hormones binds then to thyroid response elements. Thyroid response elements inside the nucleus, they have the capability of binding to transport to thyroid response element in the absence of thyroid hormone, suppressing the expression of genes. The genomic action, the positive regulation, the binding of the thyroid hormone T3 to the thyroid hormone receptors positively regulates the expression of myosin heavy chain alpha, of circuit 2, sarcoplasmic endoplasmic reticulum calcium ATPase 2, and beta 1 adrenergic receptors, and negatively regulates myosin heavy chain beta, phospholamban, thyroid hormone receptor alpha 1, and thyroid hormone transporters, a sort of negative feedback. The increased expression of the faster contractile isoforms of myosin heavy chain alpha contributes to improving systolic function. They are faster, producing tachycardia. The more expression of SERCA2 and the inhibition of phospholamban allows the reuptake of calcium inside the sarcoplasmic reticulum, allowed much time for relaxation, ventricular relaxation, and diastolic filling. There is positive upregulation of beta 1 adrenergic receptor. This produces an inotropic effect, and there is another chronotropic effect through both genomic and non-genomic functions on the adrenergic receptors on the sodium, potassium, and calcium channels. The non-genomic actions and the hemodynamic actions occur on the plasma membrane, regulating ion transporter activity through the activation of sodium, potassium, calcium membrane ion channels, effect on the mitochondrial membrane and mitochondriogenesis, affection on signaling pathways like PI3K, AKT pathway, with production of nitric endothelial nitric oxide and reduction in the systemic vascular resistance through vasodilation. Other factors can lead to vasodilation, including increased calcium uptake in the sarcoplasmic reticulum of the smooth muscles, of the vascular smooth muscles, and increased tissue metabolism and thermogenesis. There is also activation of the renin-angiotensin-aldosterone system as a result of decrease in systemic vascular resistance. Thyroid hormone stimulates erythropoietin production as well. First, we are going to talk about hyperthyroidism effect on the cardiovascular system. And here we confronted case 1, a 70-year-old female, referred from a cardiologist. He wrote that a case of thyroid toxicosis despite low heart rate of 58 beats per minute, the TSH is suppressed and free T4 is elevated. As we all know, the most frequent clinical effect of hyperthyroidism with respect to the myocardial function is sinus tachycardia, manifested by the patient as palpitation and decreased exercise tolerance. The most common arrhythmia is atrial fibrillation. New onset atrial fibrillation. Patients with new onset atrial fibrillation, 13% have hyperthyroidism, and 10 to 15% of patients with hyperthyroidism have atrial fibrillation. The risk is old age, ischemic heart disease, congestive heart failure, and valvular heart disease. How is that? T3 increases systolic depolarization and diastolic repolarization, decreases the action potential duration, decreases the refractory period of the atrial myocardium, and decreases AV nodal refractory period. This facilitates occurrence of atrial fibrillation by spreading of activity from ectopic focus from the left atrium. The beta-adrenergic receptor density and sensitivity is also increased in case of hyperthyroidism. This leads to increasing positive inotropic, dromotropic, and chronotropic effect. Other forms of arrhythmia like atrial flutter, other supraventricular tachycardias are less common. Ventricular tachycardia is rare. Back to our patient. Bradyarrhythmias are rare to occur in cases of hyperthyroidism. Sporadic reports of sick sinus syndrome and atrioventricular block, and this represents a challenge to the treating physician. Some of the patients present first with the bradycardia, others present first with the hyperthyroidism because that effect of excess thyroid hormone on the conduction system, inflammation, hypokalemia, and the previous use of beta blockers. The treatment is anti-thyroid drugs and correction of the electrolytes, use of atropine, and some of the patients may need permanent pacemaker. What is the effect of hyperthyroidism on the blood pressure? Overt hyperthyroidism effect is variable depending on the balance between increase in the cardiac output and decrease in the systemic vascular resistance, mainly systolic hypertension if the atherosclerosis takes the upper hand. Subclinical, there is a debate about relation to blood pressure. Observation studies showed no link. However, some of the studies showed that there is positive correlation. What about coronary artery disease? In a Rotterdam cohort study of 10,000 patients who are followed for 8.8 years, almost 9 years, even if the patient is euthyroid, higher free T4 was associated with increased coronary calcification index, cardiovascular atherosclerotic events, and cardiovascular mortality. In another study of more than 80,000 Danish patients with hyperthyroidism who are followed for 10 years, they were overt and subclinical hyperthyroidism was associated with 2 to 4 times % of the all-cause mortality and 2 to 3 times the acute myocardial infarction. What will cause that? Increased oxygen consumption as a result of increased cardiac output, increase in the heart rate, increase in the myocardial contractility, other factors like systolic hypertension, endothelial dysfunction, and thrombophilia. There is an entity called myocardial infarction with no obstructive coronary atherosclerosis that can occur in patients with hyperthyroidism resulting from coronary vasospasm. The second case, a 35-year female patient presented with 2-week history of dyspnea, palpitation, edema, raised jugular venous pressure, fine basal crepitation, and goiters. Echo showed that the patient had good systolic function and pulmonary hypertension. The TSH is suppressed, T3 and T4 are elevated. Hyperthyroidism and heart failure. Hyperthyroidism can cause de novo or exacerbate a previous heart failure. Could be with reduced ejection fraction or with reserved ejection fraction. 1 to 7% of patients with heart failure present with hyperthyroidism. 10 to 40% of hyperthyroidism present with heart failure. There is a lot of mechanism causing the heart failure, but bear in mind that early treatment and short-term hyperthyroidism, this could be reversible. Long-term untreated hyperthyroidism could lead to increase in left ventricular mass, and impaired relaxation, increase in the atrial size, and this may be permanent. Our patient that has pulmonary hypertension, this may be autoimmune mediated through endothelial remodeling or mechanical from increased cardiac output or decrease in the pulmonary vasodilators or increase in the pulmonary vasoconstrictor or enhanced pulmonary vasculature to catecholamines. What is the effect of hypothyroidism? Hypothyroidism rarely leads to significant arrhythmia. However, the ECG changes in patients with hypothyroidism usually shows sinus bradycardia, low voltage activity, prolonged action potential duration, and QT interval. About the effect on the blood pressure, two factors in hypothyroidism can lead to hypertension, including the increase in systemic vascular resistance and the arterial stiffness. Numerous factors can contribute to the endothelial dysfunction like hyperlipidemia, thyroid autoantibodies, and low-grade chronic inflammation. There is free water retention from reduced glomerular filtration rate, decreased renal blood flow, or increase in the ADH. Similar results in patients with subclinical hypothyroidism, they also have increased incidence of hypertension. About heart failure, overt hypothyroidism causes diastolic dysfunction as a result of decrease in circuit 2. This impairs ventricular relaxation and reduces the preload. Subclinical hypothyroidism is also associated with increased risk for heart failure. So there is decrease in the preload and decrease in the afterload, and this finally leads to decrease in the cardiac output. Case 3, which is a 20-year-old female patient, 6 months history of lethargy, constipation, and dyspnea, raised jugular venous pressure, muffled heart sound, chest X-ray showing cardiomegaly, echo shows cardiac tamponade, TSH is markedly elevated, the free T4 is low. This is pericardial effusion, it's rare, occurring to 3 to 6% and rarely tamponading. The mechanism is unclear, usually the high cholesterol content of the pericardial effusion. The cause may be increase in the capillary permeability or decrease in the lymphatic clearance. What about the thyroid and the cardiovascular risk? The fourth case, a 52-year-old male patient referred for the management of newly diagnosed hypothyroidism. The TSH is markedly elevated, the free T4 is low, the total cholesterol, LDL, HDL, and the triglycerides are all elevated. This is hyperlipidemia, as you all know that. Hyperthyroidism reduces the cholesterol level. In a study, they found that there is an increase of after correction of hyperthyroidism, there is an increase of 31 milligram per deciliter of the LDL after correction of hyperthyroidism. So the lipid profile should be reassessed after attaining the euthyroid state. Hypothyroidism is associated with significant increase in the lipid parameter, elevation of the LDL, oxidized LDL and lipoprotein A, and decrease in the triglycerides. This may cause decrease in the LDL receptors or increased activity of 7-alpha hydroxylase, decreased breakdown, or low lipoprotein lipase activity. So, according to the Endocrine Society, patients with dyslipidemia should be screened for overt hypothyroidism. Need for lipid lowering therapy should be reassessed after attaining the euthyroid state. And a study that after attaining euthyroid state, the LDL reduced by 24% and the triglycerides by 18%. In subclinical hypothyroidism, the rate is lower, about 8% from the baseline. There is increased risk for thrombosis. Patients with overt and subclinical hyperthyroidism, there is increased markers of thrombogenesis like fibrinogen, factor 10, and von Willebrand factor. There is increased incidence of cerebrovascular stroke, maybe due to increased thrombosis, increased carotid intima thickness, or due to the atrial fibrillation. In case of hypothyroidism, there is different effects. Severe hypothyroidism, there is increased fibrinolysis, and in subclinical hypothyroidism, there is more hypercoagulable state. The effect of thyroid hormone on platelets is unclear. We all know that there is something called the non-thyroidal illness, or the changes in the thyroid gland, thyroid hormone that can occur in critical illness. The most common of them is that low T3 syndrome. Low T3 syndrome non-thyroidal illness can occur in 15 to 20% of patients with acute myocardial infarction, 20 to 30% of patients with heart failure. Low T3 is always associated with worse prognosis. And then finally, there is modulation of the thyroid hormone level by drugs that impact the cardiovascular system. The most important of them is amiodarone, and the amiodarone effect as an antiarrhythmogenic may be due to the high iodine content or a direct toxic effect on the thyroid parenchyma. And there is hypothyroidism induced by amiodarone, occurring 5 to 22% of the cases, and amiodarone induced thyrotoxosis in 2 to 12%. Okay, just propranolol, one of the common drugs that can be used in patients with thyrotoxicosis. It's used because of the additional effects, like non-selective beta blocker can reduce systemic symptoms such as tremors and anxiety, membrane stabilizing action, and reduction in serum T3. So my take-home message: thyroid hormones are important for normal cardiovascular functions. Thyroid disorders are associated with significant cardiovascular morbidity and mortality. Early diagnosis and treatment of thyroid disorders prevents long-term cardiovascular complications. Cardiovascular drugs can impact the thyroid functions. And thank you.